Okay, and then obviously what do? The area that is aganglionic has to be removed. So ultimately, they need to have surgery, remove that area. And then obviously with any GI surgery, you want to watch for infection and kind of, monitor because they have a higher risk of flushing. Extrahepatic biliary atresia. This is again at birth, and it's caused by the unnatural development of the common bile duct. And because the closure of the common bile duct is there, the bile duct fibrosis, and the bile duct is not open, bile cannot pass. Pancreas can't pass insulin, and the bile duct can't pass bile. So it sits there, and it builds up in the liver and causes breakdown in the liver. And this is all occurring in utero even, where the bile is just increasing in the liver. So these are infants that are usually born very jaundiced after they're born. Liver does not kick in. They're already in liver failure to some degree when they're born. So these are the most common types of children that need liver transplants very soon after birth. They usually can only accommodate a few months, and then they need a liver transplant. The good news is liver transplants can be done with live donors. Only 25% of an adult liver is all that an infant needs. Khalid's shaking his head.
Yeah, the liver always has to regenerate.
It does. Actually, they say within a few months, definitely within 6 months to a year, that adult liver will regenerate itself. The problem sometimes is that when they go to take part of a liver and put it into the infants, you can have clotting issues. You got to get all those, the hepatic artery. Everything's got to connect just so. It's got to be so proper, and then they can't reject it. So those are the big things. Obviously with any transplant patient, but they do require the transplant very early. So again, they're usually asymptomatic, but then you'll get some abdominal distension, bruising, jaundice, intense pruritus, all those signs and symptoms of liver failure. Why do you get intense pruritus with liver failure? Well, red blood cells, the breakdown of those will actually increase your bilirubin level. And the bilirubin will cause, increased bilirubin causes the intense pruritus, exactly. So tea-colored urine, again, from that. Stools will be putty, white, or clay-colored. Why? What gives stool their color? That's right. Failure to thrive in abnormal liver functioning test, and they need a transplant. Sometimes if they're awaiting a donor and they're awaiting a match, they can do something called the Kasai procedure. All that does, it does not, the liver's already in failure. What the Kasai procedure does is it actually opens up the common bile duct. So it does buy them a little bit of time, but it's palliative. They still need a new liver because the liver is damaged. Intussusception, you can briefly go over. Again, in your books, you want to look at it. It's a portion of the intestines that telescopes or vaginates on itself. So you want to review that too. When you have a part of the intestine that telescopes onto itself, you have one part that now is, strangulated, or it is strangulated, what's going to happen? That's right. So when you have a strangulation in an area, it's going to cause decreased blood flow to that area. With decreased blood flow, you're going to have necrosis eventually over time, and then you can have perforation and septic, like it says, perforation, peritonitis, and septic shock. So anytime there's a telescoping like that, where one part goes back onto the other, they have to treat it fairly quickly. And the most common way and here's just a picture to show you what happens. Why does that happen? It happens because of reverse peristalsis that the infants have. So it's one of those things that, because they have reverse peristalsis at times, it can happen. So usually barium enema will show them the obstruction. It can happen anywhere from 3 months to 5 years of age. Acute pain, a palpable sausage-shaped mass in the upper right quadrant is classic. Vomiting and current jelly, which is like clotted stools. So a lot of times they will try this hydrostatic reduction, where they'll actually try to push depending on which direction it's in. But most commonly they have to go in and do surgical intervention and remove the piece that has been strangulated, because now it's become necrotic for too long and ischemic for too long. They have to remove it. Necrotizing enterocolitis. So let's go back to preterm infants again. Okay. By the way, cardiac and GI are very big for your next exam, obviously. cardiac and GI are big areas. And special needs, which we'll be doing next week, are other big areas. So when you're thinking about big areas in pediatrics, it's cardiac, GI, special needs.
So don't focus on the rest.
Huh?
Just don't spend your life having the rest of it. Just focus on the
Well, you're gonna have things from the rest of it too, but these are gonna be, big questions. Like content-wise, like when people wanna say like how much, and obviously you have that breakdown already in your test blueprint, Necrotizing enterocolitis. Okay, so you have an infant that had this respiratory incident at birth. So they cannot breathe on their own. Preterm infant, okay? Preterm infant, they can't breathe on their own, so they're put on oxygen. When they're put on oxygen, they're not feeding. And because the intestines have not fully developed either, because at the very end of the pregnancy is when they get a lot of their oxygen, a lot of their blood flow, they start to get more and more of those ancillary blood vessels that develop. But because that has not happened, because they were born preterm, and now they're on high pressure ventilation oxygen, they're in this fight or flight mode. Remember we talked about that? They're in fight or flight. Just on this high pressure oxygen, because they had a decreased oxygenation status. So now they're gonna, now they're going to kind of increase their heart rate. But when all this is going on, the parasympathetic is also not sending blood flow to the intestines. Plus they had decreased blood flow that occurred when they were born because they didn't get the full developmental period. So they have a risk for something called necrotizing enterocolitis, because you're also not using the intestines. So if you're not using your intestines over time, there's less blood flow that will go there too. And you can get necrotic patches that will start to occur. It is acquired over time in infants that have high pressure ventilation. So this goes through that again. Generally, if infants are fed some sort of breast milk or formula into the GI tract, they will have very good results. So what they found is they are decreasing the incidence by putting in NG tubes in infants when they're born. So if they do have a respiratory event and they're put on high pressure oxygen, they will put an NG tube in and preferably give them breast milk. And if they can't give them breast milk, then they will give them formula, and they usually do well because their GI tract starts to be stimulated to work, and then it will help to send blood flow to that area. Clinical manifestations when they start to get necrotizing enterocolitis is something called a pneumatosis intestinalis. It's a really enlarged area of the intestines that are building up with gas, because they get very gassy because they're not getting blood flow to the area. So they have lactic acid and breakdown. Distended abdomen, blood in the stools, poor feeding, gastric retention, and lethargy, because they're not, feeding properly. So again, that pneumatosis intestinalis is seen in x-rays. It's a sausage-like dilatation of the affected intestines. When you see this, that infant needs to be kept NPO. Everybody see that? So this is again where the book contradicts itself, because they'll say, well, you just told me when the infant was born, I want to give them an NG tube and feed them. And now you're telling me I don't feed them. So which is it? When an infant is born, okay, they don't have this. They develop it because they are not fed and because their intestines become inactive. So the blood flow is not going there. So then they can become necrotic. And then they can develop into this. Once you have this, they must be NPO. But to prevent this, you want to feed them. And you can't feed them PO because they're on a ventilator. So that's why you need the nasogastric tube. If they're going to be on a ventilator for a long time, a G tube. But you have to use their intestines. But once you suspect this, you must keep them NPO. Why? That's right. Because if you feed somebody and they have all this high pressure, think of a balloon, right? And then you stick something else in it, what's it going to do? Rupture. That's right. So you want to feed them as quick as possible. You want to get a G tube in, an NG tube, feed them breast milk ideally, or any formula something, so that their intestines are working. But if you suspect, and that will keep this from happening. But if you suspect that they have this, then obviously they should be NPO. Again, the prevention is to give small volume feeds. The old belief was you shouldn't feed them when they're in this kind of a state, that it would stress them too much. But with the newest research, we've seen that this is what you want to do. And once you suspect that they have it, so that was to prevent it. Now if they have it, they must be NPO. See the difference? You would understand that? You saw it? IV for fluids and electrolytes, and G tubes, broad spectrum antibiotics once you think they have it, and no rectal temps. Obviously, you don't want to put any pressure in that area. And obviously when they're confirmed no pressure in the abdomen, no prone position, supine, or sideline. They're going to stabilize them for surgical intervention, and then they're going to have that section removed. These are infants, you might see them at Children's Specialized or other places that have had like so much of their intestines removed, because it does start to travel very quickly, that they have G-tubes and also all kinds of like colostomies and other, because they just have had so much of their intestines removed because of this. And infants who are breastfed or given breast milk are 10 times less likely to have this. Very effective. And the final thing we're going to talk about, which again I know you had in 132, so it's really just a recap, is appendicitis and appendectomies. Okay? So again, it's an inflammation of the appendix, which comes off the cecum, which actually, way back, was thought to help with when we were eating foods that were not really processed and were not really, foods that might be like roughage, really, like eating leaves and berries and things that were off of, you know, that we're just getting from the environment. So it's a blind sac that comes off the end of the cecum, and some people are more prone to this genetically, okay, because of the way that it's positioned and it's smaller and all. And some people, it's because of their diet. High fiber diets have a lower risk for this. People who are eating really greasy foods all the time have a higher risk. And it is the most common reason for emergency surgery. Because once it becomes obstructed, and you have pain at McBurney's point, and it's inflamed, what's sitting in that appendix? Feces. So again, you're going to have peritonitis and septic shock if it ruptures. So it needs to be removed. So again, pain at McBurney's point. Where is McBurney's point? Midway between the umbilicus and the ischial spine. Okay? So the iliac crest. And so, which side? Right. In 99.5% of the people. There are people who have their appendix on the opposite side. But yes, for most of the people, the majority it is. I just say that because we came across somebody one time who had it on the left side. So you never want it 100% of the time. But usually when people have pain on the left side, it's either, if it's a woman, it's usually ovarian, or it's something with the large intestine, because that's what also is over there, the colon. Okay, so pain at McBurney's point, guarding of the abdomen, low-grade temperature, nausea, vomiting, increased red blood cells, problems eating, pain on urination, because of the way the nerves run, and they do need surgery. Prior to surgery, we don't want to give them heat packs to the area. Because what does heat do? Helps to increase fluids and vasodilate. We don't want that rupturing. Quiet play, MPO is key. And post-operatively, they give a lot of different antibiotics, IV and then PO later.